So they can occur a couple of different ways. Sometimes it can be a blow to the lateral part of the knee. For example, if a football player is running and someone hits them on the outside of their knee. A more common way can also be a non-contact injury where the player pivots and then the ACL tears. So initially, particularly with older individuals, we would try non-operative management. If you're even just a recreational athlete, as long as you're not doing a lot of cutting and pivoting, you can return to general activities. However, particularly in younger people and anyone that wants to do things more athletically with cutting and pivoting, we would surgically treat it. Typically when we do an ACL surgery, we can't fix it. So you can't attach the torn part back to the other part. So you have to do what's called a reconstruction, so you get a graft. So that graft can be one of two different options: an allograft, which comes from a cadaver, or an autograft, which comes from you. Many different allograft options from the cadaver, and a lot of that's going to be based on what the hospital has or what your surgeon has a preference with. The autograft is kind of the bigger decision. The three different options: the first is called bone tendon bone. It comes from the bottom of the kneecap, the middle of the tendon, and then part of the shin bone, which is the tibia. That's a great option. It's considered the gold standard. It's the most well-researched. The only issues with it can be sometimes people can have a lot of residual pain in the front of the knee and sometimes have some difficulty getting extension. The second option is a hamstrings. That's a very good option. It's very strong. It's easily harvested through a small incision. Athletically, people typically do very well. Some of the problems are it can occasionally loosen out a little bit more than the other options, and sometimes it's just not big enough. Particularly in smaller individuals, the graft might not be the right size. The third option is a newer option, which is your quad tendon. As a graft, it's very strong. It does a good job. You can pick whatever size you want for that graft. It also doesn't seem to loosen out the way that some of the others might. The only problem with the quad tendon can be rehab. Whenever you have an ACL reconstruction, your quadriceps, which is the muscle on your thigh, will atrophy. And if you're taking part of that tendon, it can be difficult later on in your recovery process to get all of your strength back. All the options are great. They all do really well. Typically, you want to pick a graft that you're comfortable with and also your surgeon's comfortable with. So ACL, typically pretty early on, within about 6 to 8 weeks, you can be walking even without crutches. Some of that's going to depend on whether or not your meniscus has to be managed. You can be running at 4 months. Typically closer to 6 months, you can begin cutting and pivoting. Depending on how you're doing with certain rehab parameters, we can a lot of times get you back to sports around 8 months. Realistically, you're not going to be the athlete that you want to be until probably 18 months. It takes a long time to get your explosion back and be able to cut and pivot with power. But again, the goal typically is around 8 to 10 months to get you back to being on the field.